Good afternoon, everyone, and thank you for joining us today for our webinar, Building Healthy and Resilient Communities in the U.S. Virgin Islands. My name is Jelani Newton, and I'm a Senior Director with Enterprise Community Partners. My colleague, Alon Mitchell, and I will be your webinar hosts today. For those that are not familiar with Enterprise, we're a national nonprofit. We focus on housing affordability, economic mobility, racial equity, and community resilience, and we work in communities across the country. We've been working in the U.S. Virgin Islands to support the recovery from the 2017 storms with a number of activities with local partners. Some of the activities we've been working on include the development of information resources, such as our Keep Safe guide for building resilient homes and island communities, as well as a series of in-person and virtual workshops focused on community engagement and nonprofit capacity building in support of resilience in the territory. Speaking of our workshop series, we want to take a moment to thank our amazing partners at NeighborWorks. NeighborWorks has been working with us and has been supporting this webinar series since 2020, and they share our interest in advancing housing access and community resilience in the territory. So we're really happy to continue working with them. Also want to take a moment to thank our amazing local partners, several of which you'll be hearing from today. We recognize that the recovery work is very difficult work. We recognize that various nonprofit, government, and other leaders in the territory are really doing the hard work on the ground to benefit the community. As a native of the Virgin Islands myself, I take a lot of pride in the great work that those folks are doing and truly appreciate all the impact that they're having on the community. With that, I want us to go ahead and jump into the webinar. Before we get started, I'd like to just make a couple housekeeping announcements. So just to note for everyone, the webinar is being recorded. The slides and the recording will be shared with all registrants after the webinar ends. Please note that all attendees will be muted throughout the webinar, but you can use the Q&A panel, the Zoom Q&A panel at the bottom of your screen or the top, depending on where your taskbar is, to ask any questions that you might have as we go. We'll be saving time at the end to answer questions so that we can get through all the content. But please do, as questions come up, feel free to put them in the Q&A. If you're connected to the audio right now, you're connected through one of two mechanisms. There's phone audio, and then there's the computer audio. We recommend using phone audio if you're having any trouble with your computer bandwidth or any other issues. Folks seem to have had a better experience in the past with phone audio. And if you need to switch from computer audio to phone audio, you can use the little directional button there that goes to audio settings and just click switch to phone audio. Okay. So with that, I'm really pleased to introduce our amazing presenters for today. We have Ms. Romy Hall, who's the Director of Healthy Homes and Communities with NeighborWorks America, Ms. Hillary Lohman, Coastal Resilience Coordinator for EPNR in the USVI government, Dr. Gregory Guanel, Director of the Caribbean Green Technology Center at UVI, Mr. Marvin Nesbitt, the Director of Resident Wellness and Empowerment with the VI Housing Authority, and Ms. Masuri Sproul-Webster, the CEO of FHC, Frederiksted Healthcare, Inc. To quickly review today's agenda, we'll kick off with a few opening remarks and then jump right into our featured presentations. We'll start with some national models for advancing equity through the community health worker and model and housing. We'll talk about measuring need and impact locally through the Social Vulnerability Index. We'll talk a bit about equity considerations and hazard mitigation planning. We'll hear about the Bright Path strategy from the VI Housing Authority, and then we'll hear about some of the great work that FHC is doing in the St. Croix community. Then again, we'll end the day with a short question and answer section. All right, so without further ado, I'd like to hand it over to our Ms. Joni Straussman at NeighborWorks for opening remarks. The floor is all yours, Joni.
Thank you so much, Jelani, and thank you for everybody who's joining us today. And thank you to the wonderful panelists. I'm so excited to hear this webinar. It's really a pleasure to be here on behalf of NeighborWorks America and to welcome all of you to this important webinar. Romy Hall, one of the panelists, will speak a little bit in a little while on who NeighborWorks America is, so I will spare you that information. But I will say that the Virgin Islands is part of the Northeast region of NeighborWorks America. And through the years, we've worked closely, mainly with the Housing Finance Agency, providing training slots to our national training institutes. But after Hurricane Maria, we were determined to do more. And as Jelani said, we were thrilled to be able to partner with Enterprise to provide a series of webinars on various topics due to how Hurricane Maria affected your islands, your beautiful islands. And this webinar is actually the last in the series of these webinars. But like all the webinars, this topic is critical and timely. We've always known how critical health is to a person's well-being. But in the last few years, with COVID, which is still raging, it has become even more relevant. And we have learned that you can't just isolate health from other aspects of people's lives, from housing, from work, from education, from wealth building. It's all connected. And so you will hear today from about various programs and strategies, both nationally and wonderful work on the islands that look at health with a holistic approach. So I'm really excited to hear from the panelists. I hope you are too. Welcome again. It's a pleasure that we were able to provide these webinars. And I'm going to turn it back to Jelani. You're on mute, Jelani.
Thank you. Sorry about that. Saying thanks so much, Joni. And with that, I'd like to turn it over to Ms. Romy Hall.
Hi, good afternoon, everyone. Thank you so much. And I think we'll move to the next slide. Great. So for today, what I wanted to do was to share with you a little bit about NeighborWorks, and then particularly talk about a model that we are advancing and supporting our network to advance the community health workers, and how we're supporting our network of organizations to implement an affordable housing and community development with a particular eye around health equity. So next slide, please. So as Joni shared, we both work for NeighborWorks America, and NeighborWorks America is a congressionally appointed organization with nearly 250 affordable housing community developers across the United States, also in every state in the United States, DC, and also Puerto Rico. Our network, they are all doing high impact, locally oriented, and resident-driven work. And as you can see, our network includes moving homeowners and rental units, and securing and leveraging investment from Congress to the tune of nearly $17 billion, and that's just in the last fiscal year. We also do a lot of work around partnering with health and supporting our network to really explore this sort of burgeoning field at the intersection of health and housing, from creating and then looking at shared language and understanding, all the way to thinking about health outcomes and impact. Next slide. So as we started to think about this conversation today, wanted to start with some framing, and as Joni really shared, thinking about this holistic approach to health was really framing the social determinants of health. And what is this? And so I really like this framework from an organization in the San Francisco Bay Area that's called BARHI, or the Bay Area Regional Health and Equity Initiative. And they really showcase a public health framework around reducing health inequities. And oftentimes we might think that our health is really based on how we have access to health care or prescription drugs, but it's much more expansive and broader than that. And so it's really thinking about this continuum of health from upstream. So what happens sort of at the top of the stream influences what happens at the downstream. And so what it really starts to take into account is how social inequities like class and racism, as well as institutional inequities like what happens in schools or laws, can really then inform what happens into place, the living conditions, which then sort of informs what happens when you see disease, mortality, and injury. And what's really key about this work, creating healthy communities, being healthy individually, is much more comprehensive than just the health sector. And Jelani, if you click twice, Great. You really start to see when you look in the living conditions area in the midstream along this continuum, you really see how much affordable housing, community development, and also health partners are really creating that bridge from upstream to downstream to creating health. So as we begin to think about this, and next slide, in the health and housing context, there's been this great research, and I can drop in later a health affairs article that's really trying to summarize what are those 4 pathways into health and housing that really can mitigate healthcare costs while improving health outcomes. And the way that's been really thought about is thinking about the stability of residents in housing, the quality and safety of the building materials, to the affordability. The less you spend on affordable housing, the more you have to spend for rent, social activities, food, medicines, etc., and then the neighborhood, and really thinking about the context of the neighborhood and how it creates these opportunities in place for people to be healthy. And so next organization, next slide, please. So one of the things that we did is when I started my career at the intersection of health and housing, almost 15 years ago, it was sort of new. And what's been amazing to me in this last year, we did a survey and we found that our network organizations, nearly 70% of our network organizations are doing some kind of activity at the intersection of health and housing, which is pretty impressive when about 15 years ago, this was sort of new. We didn't know what this means. And what was really exciting to see is how organizations in the next slide really pivoted to think about COVID-19 services and programs. And in particular, while rental relief was really a big focus as part of their services and supports that they provided to residents across the country, you also started to see this work around vaccinations, food security, mental health, and community health programs that really started to provide this sort of connection into health and housing and some new interest in ways to connect the dots and support communities throughout the pandemic and beyond. And so on the next slide, at NeighborWorks, we started to really see, when you started to look at, we started to explore this exploration of a model before the pandemic and looking at community health workers, but then we started to see the network is really, with the pandemic and even before the pandemic, really looking at health and housing. A lot of the work of community health workers really mirrors that of affordable housing and community development. And also with COVID, there's just so many new partnerships that have been built and relationships that started to lean into, yes, how could we look at the community health worker model as an opportunity to support communities, as well as really kind of add this next layer of health and housing to affordable housing community development. Next slide. And so just to ground some definition, what is a community health worker? A community health worker, it's a frontline public health worker. And what I really like to think, it's a liaison between community and institutions. Often the community health worker, it's not really sort of a specialty in that schooling or that you need a particular level of education. The specialty is, can you build relationships? Are you trustworthy? And have you had the experience of navigating some hard systems, particularly around healthcare and other sort of social services, and being really that liaison and counterpart and trusted partner to help support individuals, empower individuals to support them to get what they need. So on the next slide, you might have heard some of these names like promotores, care coordinators, health and wellness program coordinators. We really started to look at NeighborWorks. What might be the different ways besides community health workers that our network are using these terms, or resident services coordinators? Next slide. So the other thing I just wanted to highlight, these two cases that were stories from our network who are implementing community health workers and what their clients have said, and really acknowledging that community health workers are lifelines to clients. It can really help connect the dots, get folks into support services, and really sort of navigate some of the conversations that are hard to have with residents or with systems, doing individual advocacy with community to ensure they get what they need, all the way to a resident working with neighborhood. It's a different kind of fire. So it's really creating those connection points in community in a different way. Next slide. Okay, so I wanted to talk a little bit about just quickly the three models that we're looking at of community health workers as we look at this intersection of community health workers with health and housing. Next slide. So one of the things that we're sort of focused on is senior programs and family programs. In the US, a lot of affordable housing properties are sort of organized by populations, seniors and families. And we wanted to recognize that in our network and with many organizations beyond affordable housing community development organizations beyond the network, there could be some specific community health service coordination model that have senior focus where you're looking at access to food, medication, assisting with healthcare, sort of aging in place and offering linkages to healthcare providers that and telehealth, which would be very different than family focus where you're looking at kindergarten readiness, school readiness, continuity of supports with some of the same pieces of work and also working not only with kids, but particularly their parents. Our second model on the next slide that we looked at is a one-stop shop model of addressing multiple supports. So this way could give sort of the flexibility of organizations rather than being population specific. They could work beyond affordable housing in a larger community development or in communities to really just hone in what are the supports that residents need at a particular time and connect them to housing, connect them to social services, food access, and really being a one-stop model. And the last model we looked at on the next slide is looking at a health condition model. So this model is really supporting and sort of your touch point is maybe working on asthma, or maybe it's working on diabetes, or maybe it's on hypertension. So it doesn't preclude you from working on other things that residents are acknowledging that they need support, but it's just crafting that sort of touch point into where you can have community health workers. I think this different modeling and thinking about this could be really leveraged as you think about resiliency and way to support residents and having as sort of an entry point of conversation that then connects them to a rich body of resources. So in the next section, next slide, and we can move ahead a slide. I wanted to just spend really quick briefly talking about health equity, and collectively as we're thinking about this work about health and housing is how do we advance health equity? And these two definitions to the left, I include the Centers for Disease Control and the American Public Health Association. Those definitions really talk about health equity is achieved when every person can attain their potential. But the Robert Wood Johnson Foundation, which is the largest health foundation in America, they fund 1% of all health initiatives across the United States. Is about, and the piece that I really love about this definition, that it requires removing obstacles to health, like poverty, discrimination, and their consequences. And this community health worker model is really honing in and focused on how can we improve health opportunity. So on the next slide is thinking, and we can skip ahead to the following slide. And this is one of the pieces we've been really thinking about is our resident engagement continuum. One of the things that's really important in creating a healthy community, and you think about sort of that continuum from upstream to downstream, you also sort of think about the stability pathway and sort of the 4 pathways that I talked about in creating health. I cannot stress enough the importance of resident engagement, and the community health worker model is really embedded in these higher levels of engagement. It takes increased capacity. This resident engagement continuum was adapted from the International Association of Public Participation, where they really started to sort of theorize and help folks understand this larger continuum of engagement and community building and how to connect with people, because this is what fosters healthy communities as well. Being able to collaborate, being involved, being able to transform and be empowered in support of your health, engaging residents in the conversation of what needs to happen in this neighborhood, this community, and then really working to address those barriers that are stopping folks to create that stop folks from being healthy. This is a part of the important work of community health workers, and one that's really creates the opportunity for creating health impact. And so just to wrap up on the next few slides, one of the things we have, and we can skip ahead on this slide, we will be releasing in the fall of 2022, so I hope to share it with everyone here. It's a toolkit on how do you take this community health worker model and adapt it into affordable housing and community development. So on the next slide, you'll have a sense of some of the topics and components that we're looking at, thinking about the work environment, the health equity and engagement, to data, all the way to understanding state and local policy environments, which are a little bit different. And I'm looking forward to hear more from the other panelists. But just wanted to share that there's this burgeoning work that's happening at NeighborWorks and in the larger affordable housing field to really kind of unpack and understand health and housing through community health workers. And so with that, I'm going to end and pass it back to Jelani. Thank you.
Thanks so much, Romy. Thanks for that information. Really, really amazing to hear about the network and hear about these national models. Looking forward to introducing our next speaker, Ms. Hillary Lohman, who will be speaking a bit about measuring need and impact locally in the USVI.
Hi, good afternoon. Thanks. Can you hear me? Yes.
Yes, we can hear you fine.
From where I'm sitting, I'm waiting for my slides to come up, right? Thanks so much. Okay, just getting on the same page. Okay, afternoon, everybody. I'm Hillary Lohman. I'm the Coastal Resilience Coordinator with the U.S. Virgin Islands Department of Planning and Natural Resources in the Division of Coastal Zone Management. And I'm very excited to share with you guys today some of the first results we have from the Social Vulnerability Index project that I did along with Greg Gwinnell and Joe Dwyer at UVI. And Greg will be speaking later about other things in this presentation as well. So thanks to them for their work on this. With me, next slide, please. So the U.S. Virgin Islands is a territory of the United States of America since 1917. It certainly suffers from a high level of poverty. There's about 22% of the population and 30% of families overall with children living in poverty. Low educational achievement with nearly 60% of students testing below standard for literacy and mathematics. Lack of access to affordable, fresh and healthy food, and limited access to healthcare. And in addition, the health disparities are some of the highest in the country, according to recent data from the USVI Department of Health. Next slide, please. At the same time, the U.S. Virgin Islands has experienced and will continue to experience a variety of natural hazards, from hurricanes, which bring high winds, rain, and storm surges, to rainstorms and earthquakes, tsunamis, and certainly increasingly droughts and epidemics caused by natural things like mosquitoes and other viruses, and natural things like COVID-19. So creating a social vulnerability index for communities of the Virgin Islands is pretty critical to understand the social determinants of health for the most vulnerable people here and create appropriate policy and resource allocation and interventions to protect them from adverse outcomes, in particular during and after disasters. Next slide, please. So the Social Vulnerability Index, as it is named, is a product method from the Centers for Disease Control. So why does the CDC produce a Social Vulnerability Index? They produce it at the county level for every county, for every state in the United States to help public health officials and local planners better prepare for and respond to emergency events like hurricanes, disease outbreaks, or exposure to dangerous chemicals. Socially vulnerable individuals suffer more adverse disaster outcomes for various reasons, including being less likely to afford emergency expenses or be able to evacuate, and are more likely to have pre-existing health conditions and or be more likely to live in substandard housing that is unable to resist storms or which are in hazard-prone areas. Next slide, please. So what information is, so we adopted this CDC method and made it work for the estates at the estate level of the Virgin Islands. So first we'll start with what does the CDC-SVI, where does that data come from? It's the US Census data. We did it for the US Virgin Islands based on 2010 census data because the 2020 data hasn't been released yet. We will be able to do this for the 2020 data when it is released. But there are pretty much 4 themes: socioeconomic status, household composition, minority status and language, and housing and transportation, that those are sort of the buckets or themes of social vulnerability, and each of which have census level variables that are bucketed in to be indicated by those themes. So next slide, please. With those themes and variables in mind, when we made it work for the Virgin Islands, we came out with, there are 335 total estates in the territory. We worked with the 268 estates that had at least one person, according to the census, living there. The only census tweak we had to make was that the youth age bracket for the Virgin Islands census data includes those aged under 19 instead of just under 17. And we felt pretty okay about making that part of our method. Again, grain of salt, it's the 2010 census data for now. And it is ranking each estate against other estates across the territory, not at the island specific level, not St. Croix estates within St. Croix, but all of the estates compared to one another, which we will talk about more. Next slide, please. So these images, they're certainly not to scale. I'm just going to talk briefly about how the method occurred, and these images are just layer specific results to show what some of the data that we have looks like. So to account for the difference in population between estates, we calculated the percentage of the population that fell into a particular variable category for each census variable in each estate. So for example, the number of people aged 65 or older divided by that estate's population total. And then ranked and ordered the percentages for the variable from the lowest to highest. Estates with a 0% value, so nobody in that estate fell into that category, were scored with a 0, indicating that they did not have that's the lowest vulnerability score you could have. Once they were scored, the estates were divided into equal quartile groupings. So there are 4 ranks, highest to lowest vulnerability. And also then we flagged the estates that had the score in the top 10%, AKA the top 90th percentile of vulnerability. And this would help account for estates where certain variables had low vulnerability, but that ranking might mask other variables with particularly high vulnerability in the overall score. So that's the method. Again, we can talk more about that, but I'll carry on for the purpose of the presentation. Next slide, please. So then we summed all of the 4 theme categories, and here we have the overall social vulnerability. The regions with the highest social vulnerability correspond to areas that have high socioeconomic and household composition and racial and housing and transportation vulnerabilities, which was each of the theme categories. They tend to be regions with high population density with many low-income housing developments, which is a layer we added on later to show that that is so. The most vulnerable regions are certainly estates in and around WIM and the Frederiksted area of St. Croix, also Bovoni and Charlotte O'Malley and St. Thomas. Estates in St. Croix that are west, which is directly downwind in and around St. Croix's South Shore oil refinery, and also as well as areas in Tutu and St. Thomas show very high overall vulnerability. Next slide, please. So this method for this geography and population of the Virgin Islands is, we think it's representative in terms of St. Thomas and St. Croix. St. John, we're not sure if it was the right fit, and this is a great example of how CDC's social vulnerability method does not by definition necessarily become reflective for characterizing the US Virgin Islands, but we definitely wanted to give it a try. So St. John is a good example of a geography that shows where some of the estates are geographically capture some very extremes of data and demographics of people living in the Virgin Islands. So that estate, then the data becomes less than representative of certainly the extremes and more representative of what's in between, which perhaps isn't what's actually there. So St. John also has a much lower population than the other two islands. In particular, 54% of this island, and mostly in the interior where you can see where there's no residents, is national park land. And so the data from these estates in St. John may only represent very small populations of fewer than 25 people. But they also beg the question of how else can we consider social vulnerability to characterize the Virgin Islands. So we have, this is a good example and time to say, we have a few questions and concerns about the results regarding estates with small populations, the role of other geographic isolation, and the role of minority status in a territory compared to the role of it at the national census data. And I will just say that we've spoken with researchers in Puerto Rico and Guam, and they have found similar results and further questions pending, which is pretty interesting, and we continue to talk about it. Next slide, please. So to the final bits about what else we did with the CDC method of social vulnerability index by state. We also found that most of the urban populations in St. Thomas and St. Croix have high levels of social vulnerability. There are also, many of these populations are at greater risk of exposure to flooding and potentially high noise and air pollution. In St. Croix, they live downwind from the major industrial area that includes the refinery. And so we added, next slide, please. We overlaid this data with things like the floodplain and areas of shelters and industrial areas and things like that. So again, this research is forthcoming. I'm trying to use time wisely. I guess I highlighted areas of interest. Certainly, this is with regard to the floodplain. So I mean, again, the same areas keep coming up. Bavoni, which is where the landfill is in St. Thomas, and Tutu in that whole eastern area, Charlotte Amalie, the Kings Hill Airport. These are all areas where flooding is an issue and where people seem to be the most socially vulnerable. And so the most obvious implication for public health is the fact that many of these people live in or have to travel through flood zones, also have high social vulnerability. And we certainly, it begs the risk of contamination and injury from chemicals and sewage overflow, and the US, considering that the Virgin Islands does have a pretty deficient wastewater system, though it's intended to be improved. Next slide, please. This is again just highlighting those landfills and industrial areas, the refinery on the South Shore. The wind comes from the east, so everything red is downwind of that very large oil refinery in terms of air and noise pollution. The airport's there. And then in St. Thomas, again, we see Bavoni, the landfill, the airport, Charlotte Amalie, all of these really, really red areas. So next slide, please. Again, there's a lot more to talk about there, but I want to, in the interest of time, just say that what we're doing next with this is using this. Certainly, there's a lot of research questions still to be answered, but we're certainly trying to share this with local agency partners so they can start using it and benefit cost analyses. Certainly, since the federal government is interested in building equity into a lot of its funding programs. I think this could be a great tool to help provide that data and quantify that sort of information for projects in the territory. And certainly it can help immediately. We work closely with Vitima. They know we were doing this as well. And we look forward to sharing these results and making sure things, when hazard events like hurricanes or droughts or whatever come up, that everyone can just use this tool specifically or non-specifically to really hone in on resource allocation and response and preparedness tools. So the next slide is my last slide. Thank you very much. And this is the materials that will be coming out for people to use in about a month or so. We'll have an interactive web map that some of those sort of still shots of the maps that I showed today. For folks who work with spatial data, we'll have that geodatabase available. for people who like data sets, we'll have the data sets available. And this publication will be coming out from the National Hazard Center, so people can use that as a reference as well. So thank you very much, and that's it for me.
Great. Thanks so much, Hillary. Great to hear about the great research and the use cases for the data that is being developed. Next, I'm gonna welcome Dr. Gregory Guanel to talk a bit about, I guess, building on this conversation, incorporating equity into hazard mitigation planning.
Yes, good afternoon, everyone. I'm just gonna follow up very quickly with some observation from the work that Hillary just presented to highlight some implication for hazard mitigation planning in the territory. So one thing that you probably, for those who are familiar with the territory, you probably saw from the presentation is that most of those places that have high social vulnerability are also urban places. And when we think about urban places, we think about social vulnerability, but we can also think about heat and higher temperature due to the concentration of buildings and a lower concentration of forests. So this is an example of, urban center in a territory. Next slide. So the thing to remember is that, when we talk about social vulnerability, as Hillary mentioned at the very beginning of her presentation, we also need to think about hazards. So currently we are in a dry sort of period. Most of the territory is in extreme to severe drought, which means that a lot of people are stressed for water. Next slide. And this drought is often exacerbated by high temperature. We can also look at this picture here we're taking after the hurricane, showing how this hurricane defoliated all the island. And after the hurricane, a lot of people were complaining about heat. Heat is one of the hazards that is not really talked about because we have nice breezes and stuff, but heat is definitely a hazard that we need to kind of think about, mostly because of the lack of rain and also because of that tend to cool stuff, the lack of trees and the impact of hurricanes. Next slide. So some effort has been done by the Weather Service, especially folks in Puerto Rico, trying to dig deeper into the issue of heat in the Caribbean. And as you can see in the tables on the right, Cotton Valley had a heat index of 113 last year. If you look at the lower table, Charlotte Amalia towards the end, third from the bottom, had a total felt temperature of 104 Fahrenheit. And what we expect is that a lot of those higher temperature will be experienced, in the future because of the impact of climate change. And so the question is, what does it really all mean, in the context of social vulnerability? Next slide. And so what we're looking at is that when you have some of those heat events, people are looking for cooling, especially people who are socially vulnerable, the elderly, the young, people who cannot afford, paying for alternate ways of cooling off, especially since we do not have, big heat emergencies in the territory with cooling centers. And so one thing that we can look at is people who have solar panel, because when you have, big heat event, there can be, if there is a disruption of the electrical system, such as, WAPA stopping working, then those people don't have the means to operate a fan or even operate an AC unit. And so what we found in the map on the left is that a lot of the homes with solar, which are indicated by these blue dots here on the map, are located in regions that have lower social vulnerability. A lot of those blue dots are located in cooler, lighter colored estates compared to some of the warmer colored estates where there are fewer homes equipped with solar panels. So it means that these people, if there is a case of energy disruption, or even if energy cost is an issue for them, they don't really have any sort of ways of escaping but to pay WAPA or suffers through heat if power goes off. And what we can see, again, to confirm what the map says, is that most of the people with solar are people with, who are above average in terms of socioeconomic status, as shown in the graph on the right, showing the average value of a home with solar compared to the average value of a building. So it's a 1.5 to 1.8 time more expensive if we look at the value of those buildings, meaning again that the more socially economically affluent do have more options here in the territory from an energy point of view. So this really confirms a lot of the findings of the social vulnerability analysis that Hilary just showed you. Next slide. And so this really was just a follow-up to the presentation from Hilary. What she demonstrated is that vulnerable population are likely to experience higher level of flooding, air and noise pollution. But we also need to think, when we think about those consequences for public health, the potential for them to suffering from more heat stress, more higher energy costs, and fewer ways of reducing their burden, especially when WAPA goes out. So it really sort of, shows the sort of more general energy needs, vulnerability of those populations, because not only the need for cooling, but the need for water, et cetera, which we didn't talk about. So that's really the short presentation that I wanted to provide, in addition to the great work that Hilary mentioned. Thank you so much.
Thank you for that, Greg. Wanted to next introduce Mr. Marvin Nesbitt from VI Housing Authority to share a bit about the Bright Path program.
Thank you, Jelani. Thank you for having us here today for this very important conversation. I think what you'll find as I go through my presentation is that much of what we designed here, or the direction that we're taking, is a direct result of some of the materials that have been presented before us. And so it certainly is confirmation for us that we are moving in the right direction. So if you can please advance the slide, please. Just to give you a little context, the Virgin Islands Housing Authority is a provider of affordable housing for vulnerable populations here in the territory. Our portfolio currently consists of 24 public housing units, about 1,500 in the districts of St. Croix as well as St. Thomas. And you're able to see here that we have a large population of residents are 18 years or younger, and we have a growing population of older individuals who are 62 years and over, which kind of reinforces the importance of the work that we're doing here. Next slide, please. So the question again, why it matters is really been answered and touched on in previous presentations. Next slide. We here at the Housing Authority are really find it greatly important to do what we can to ensure that those that we house in our communities have every chance at living a quality of life that one, they deserve, and that produces opportunities for everyone in the household to realize brighter futures. One of the things that we realize is that environment matters, and it matters a great deal. Healthy home equals or equates to a healthy quality of life for those that we serve. And so that is really what it is that we are trying to achieve. So Next slide. Many of those who are in attendance, you may have heard the Housing Authority recently kicked off the redevelopment plan for its entire portfolio. And so what that means over the next 10 years, the Housing Authority has a goal to either build new or completely redevelop every one of the units it has inside of its portfolio. That means all 3,000 units. Why is this significant? Well, this is important work because what it does is it provides an opportunity for us to improve the housing options for the residents that we serve. In addition to ensuring that they have quality housing opportunities, it provides an opportunity to ensure that they are residing in housing options that promote a better chance for them to be safe and live healthy lives during and before natural disasters. So what does that look like? We are taking the steps to ensure that the units that we're building now are able to withstand a Category 5 hurricane. That means reinforced windows, using more resilient building materials where we can, doing or installing underground utilities, and also using solar energy options where we can. And so this is really a great day and a great opportunity for the territory to help improve the quality of life for those that are considered to be lower income. In addition, what we've done is we are in the process of re-engineering our resident services department, which we now call the Resident Wellness and Empowerment Department. The purposes of this is, again, to have a comprehensive, holistic approach to how we connect our residents to the services and resources that they need in order to live healthy lifestyles. And what we are really more happy with is that this puts us in a more proactive posture to ensuring that we're able to help our residents to be healthy and be able to withstand the consequences or the impact of natural disasters and other health-related situations or that they may encounter. Next slide, please. So you can go to the next slide. So we partnered with the Corporation for Supportive Housing here at the Housing Authority to develop what we call our Bright Path model. Again, we feel like this is an innovative opportunity to design a holistic approach to touching and engaging our residents and coordinating the services and resources that they need in order to live a higher quality of life. We are moving to a third-party coordination model that we are implementing here at the Housing Authority. And essentially, we will be touching our residents in every facet or every dimension of their life to ensure that we are comprehensively building and developing plans that puts them on a brighter path for achieving some sort of positive outcomes in their lives and generational success and transformation. Next slide, please. As we went about this process, we didn't just do this randomly. We took the time to conduct a lot of research to look at best practices models across the country that we could tweak and customize to meet the unique needs of the residents here in the territory. And so what we did is we developed a model that's based upon the 7 dimensions of whole person wellness, the social determinants of health, as well as the quality housing, supportive housing model. And again, we took those pieces from each one of those and built the model that we feel will work here, again, which is our Bright Path model. Next slide. Just so a few characteristics of the model. This is as we are entered into our redevelopment plan, we have gotten agreement from our development partners to establish a 15-year tax credit equity fund that will pay for the services over the next 15 years. We're talking about a $25 million investment that can also be used to leverage additional financial resources that are needed to provide quality services for our residents. Again, we think this is a holistic approach versus what we've done in the past, where we've worked pretty random and pretty arbitrarily. Now we're in a position of where we're proactive and we're being targeted, and we're also being proactive and intentional. Additionally, what we're doing is each community now will have a community specific plan as we move forward to ensure that we're touching residents down to the individual household level, ensuring that we're developing or coordinating services and resources that meet the needs of that specific community, as well as that individual household, versus what we've done in the past, which is worked a bit arbitrarily. We're going to be data driven and outcome driven as we move forward. There's a lot of data that's been collected in the development of this strategy, and so we're allowing that data to drive the direction that we move in. Next slide, please. So what are those 7 dimensions that we're going to be touching our residents in? One, we're looking at ensuring the educational wellness of our residents. As stated in a previous earlier presentation, 60% of the students here in the territory are testing below standard in literacy and math. And so what we're going to be doing is working to reinstill the value of education amongst the residents that we serve. We are also going to be touching them in the dimension of vocational wellness, ensuring that we are able to help them with securing employment opportunities, or before that, even understanding what direction they would like to go in the employment dimension of their lives, and understanding what opportunities exist for them to put themselves in a better position to support their household. We're also going to be touching them physically and emotionally. Next slide, please. Also social wellness, environmental wellness, as well as spiritual wellness. Again, every time that we come into a contact with one of our residents and touch them, we want to touch them across each one of these dimensions every time and ensure that, again, we're working comprehensively to help them improve the quality of their lives. Next slide, please. So what you see on the screen now is just a diagram, kind of a process flow of how we are going to be working for resident success. Again, we're going to be starting with doing some needs assessments and understanding what the population really look like, what issues they're really facing, what their needs are. That actually has already began at a number of our communities that we have. And then from there, we're going to be using that data to help us develop the community specific plans for each one of our communities. And then we'll roll out those plans and monitor the outcomes and performance to ensure that we are achieving the desired goals that we have established. Next slide. And so as we do this work, we've established some values that we want to operate under as we roll out Bright Path. One, we're going to make sure that that we're working amongst strengths, ensuring that we understand and our team understand that everyone has strengths inside of them that can be built upon in order to change the course for them. We're going to be client-centered and client-focused and empathetic listeners as well. And then we're going to be working to ensure that we are touching them and engaging them on a consistent basis to help us with establishing those and building those trusting relationships as we move forward. Next slide, please. And then, of course, what's really going to be key to our ability to accomplish the work that and the goals that we've set out to accomplish, that is ensuring that we are no longer working in silos, that we are breaking down those barriers, and that we are collaborating with community partners all across the territory. And we've already began that work. We're having conversations with organizations all across the territory about what possibilities may look like to partner and collaborate and leverage the resources that we all have. One of the things we have realized is that we are all serving the same individuals. And so it makes sense for us to come together and leverage the resources that we have and achieve a bigger impact or make a bigger impact in the lives of those who are really in need. Next slide. So at the end of the day, what we're hoping to achieve and what we are hoping to see as a result of the work that we're doing is that we are setting the path for higher performing schools, healthier residents and healthier communities, more economically stable residents who are less reliant on the systems and creating strain on those systems, and that we also have safer communities. Next slide. And that's all I have, and I will turn it back over to Jelani.
Thanks so much, Marvin. Thanks for that presentation. It's so great to know that the Housing Authority is thinking not only about shelter and housing in the building, but also in the holistic wellness of the residents of those buildings. So thank you for sharing that. And then our final presentation today is from the Frederiksted Healthcare Inc. We have Ms. Masiri Sproul Webster, who's joined by Mr. Jay Woods. Welcome, and the floor is yours.
Okay, good afternoon. I'm actually driving. Oh, I'm sorry. I'm driving, so Mr. Woods will actually lead. Thank you. Good afternoon. I'm here and I'll support him.
All right, good afternoon, everyone. I want to commend the other panelists for their wonderful presentations. Can you bring up the slides, please? Okay, so first and foremost, this is an artistic illustration of our Ingeborg Nesbitt Clinic, which was established in 1995. Next slide. This is how it looks today with the entirety of our staff at that day and time out front. This was a picture of camaraderie with regards to colleagues, peers, and fellow community members in providing quality healthcare to the U.S. Virgin Islands. Next slide. So just a little bit of a historical timeline with regards to Frederiksted Healthcare Incorporated. That happened in 2000, started with 25 employees. At around 2004, we then transitioned to an additional site, which was opened at the St. Croix Educational Complex, which was a school-based health center. We then transitioned in 2012 with continued growth and a continued need for services to expand our dental services to an alternate location on the island, which Dental East was open. In 2014, we were able to open another location in the North Shore Princess area, which was our North Shore Health Center. as well as in 2015, we expanded services such as substance abuse disorder services, HIV risk reduction services as well. Through the advent of a grant in 2016, we were able to also get into the fight with regards to Zika. Some individuals may have forgotten about Zika with the advent of COVID-19, but at some point in time, Zika was a concern, especially for our prenatal population. So we were able to add services to assist on that battlefront. We also introduced homeless clinic services in 2016, and those continue to this day. And as you can see, we've continued to expand in 2018 with our Mid-Island location, as well as our current dental expansion that has happened at the Dental North Shore site, as well as currently now happening at our Lena Shelterbrand site. The slide says we're at about 160 employees. Correcting that, we're probably at about more of 179 to 180. So as we continue to provide services to the community, we've definitely needed more manpower and chosen to attack that from several different fronts. Next slide. So this is just a little bit more of the service dynamics on the island. As you can see, this is a map of St. Croix, which indicates the location of all our current sites. The color coding, though, is really what I want to focus on today. And as you can see, the dark brown color to the far left, which most of you may identify as the western part of the island, shows a greater than or equal to 60%. So what is this that we're looking at? What are we actually saying here? What we're saying is that up to and almost 60% of the population in this particular area is 200% below the poverty line. What does that mean? Basically, these 60% of the population in this area is currently surviving on less than $25,000 a year. So when we think about the increased cost with regards to just basic necessities, such as food, gas, transportation, a lot of times we don't take into consideration the impact that it has on individuals who aren't able to fluidly change their financial situation. As you look to the far right, we also see that we have a lighter color, although not so much different, but basically indicating that 50% of the population on that side of the island is also 200% below the poverty line, which basically means they're also striving and surviving on $25,000 or less a year. So with that being said, we want to continue to provide affordable services to the population, because as some of the slides or the panelists indicated before, we're seeing how every aspect of the community impacts what it is that we're trying to do. Next slide. Okay. Again, this just reiterates what I just said with regards to services that are provided in regards to the income levels. That just 2% are beyond that, but as well, just knowing that. Next slide. Insurance coverage, this just shows basically the payer mix, with 55% being covered by Medicaid, 13% by Medicare, commercial being 13%. Commercial will be your private insurances, such as your Cigna or your Blue Cross Blue Shield. Then we have those who are uninsured. Why is this significant? Because Frederick Healthcare, as a federally qualified health center, we don't refuse service to anyone. So once patients arrive for services, we definitely do our best to meet their needs accordingly. Next slide. Okay, this is just a breakdown of our ethnic dynamic. Just like how our community is quite diverse, our patient population mix is also quite diverse. Next slide. Okay, this is also a breakdown from a racial standpoint. We collect these demographics as we are currently reporting to HRSA, which gives us a designation as a federally qualified health center. And this is just a breakdown of race dynamics with regards to our population that we serve. Next slide. I do want to dive into this illustration right here, where we have the first column indicating reality, the second indicating equality, the third equity, and then liberation. So what are we really looking at? Oftentimes when we talk about the disbursement of assistance or the allocation of funds or whatever it may be, sometimes we have a tendency on the surface to say, well, you know, Joe, John, and Amy all got something. But a lot of times we don't step back to realize that there are individuals who may be identified as underserved in the community that may be more in need of allocation of services or just attention with regards to reaching to a place of equity and then into liberation. So here it is, we see on the first left slide here, we have the first individual. He's standing on 6 to 7 boxes and he's way high. And the interesting thing about this illustration is that it shows that if you really took 3 or 4 of those crates from that first gentleman and you gave it to that child or that young person, then they would now be able to have the same outlook or the same experience from a social standpoint, or even from a quality of life standpoint. So that's why we want to always just stress this illustration. So when we talk about providing assistance or supporting others, that we just don't give 25 to John, give 25 to Mary, and give 25 to Sue, but really just step back and assess the equality and then transition that into equity so we can all be liberated to definitely wonderful quality of life. Next slide. So there's a bit of the services that we provide. Want to acknowledge that we have been the awardee of the Health Disparities Reducer and Access Enhancer. So basically stating that we were awarded by the Health Resources and Service Administration, that we have impacted and made a difference with regard to providing access to care. We provide medical, dental, behavioral health services, as well as pharmacy with our 340 program, which allows our patients to get their prescriptions at little to no cost. We also provide case management services on a variety of fronts. One of those being our Division of Social and Community Programs, who focuses on the Ryan White population or the homeless population. And then we have case management as well for our chronic care individuals who may be dealing with things such as diabetes or hypertension, and definitely needs a little bit more assistance with regards to the services that they need. We've also been on the forefront of providing COVID-19 testing, as well as COVID-19 vaccinations. And one Saturday about the month, we dedicate one of our sites to basically providing an actual homeless health center day, where we strictly focus on providing clothing, shoes, clinical services, and just social interaction with individuals who are sometimes seen as not being a part of the community, but do need that social interaction to feel like they are a part of the community at times. Next slide. Okay, so again, just comprehensive services that goes into detail. We have been impacted by COVID just as anyone else has. For 2022, we're definitely shooting for a 14,000 patient goal, as well as a 45,000 visit goal. Again, we have our 6 locations, which was identified in the slide earlier on the map, and then also the services that we enhance. Next slide. I do kind of want to speak to the services that we're providing, because in listening to the other panelists, I think as a primary healthcare provider in the island of St. Croix, we've really identified that healthcare has really transcended just the 4 walls of the building. So that's why we have our case management services, which really deal with staying in touch with the patients, reaching out to the patients, communicating to the patients, are reinforcing why they need to really invest in their time and energy into primary health care. Those of us in the Virgin Islands know that sometimes we have a tendency where we use the hospital, which is really there for emergency care services, more to say so, than primary health care. And we don't have individuals who are really utilizing primary health care providers, not because they don't want to, but sometimes, quite frankly, because they can't afford to. And that's where really Frederickstad Healthcare as an FQHC is really trying to be on the front line in really trying to make sure that we provide quality, affordable care to the entire community. Here we have some still images of some of the services that we've provided over time. Here we have an individual that's receiving some food at one of our homeless health center days. We have an individual walking away, more than likely after just receiving services. As well as in the third image, we see an individual being provided with quality footwear so they can continue to walk throughout life. Next. Okay, some more images of just what it is that we're doing. We have here 2 individuals from our dental services department that is basically at one of our schools. Right now, we're definitely transitioning. We just got a mobile van that is basically going to allow us to go into the schools and really focus us more on our dental health services. There's quite a demand for dental health services. So through creativity and being innovative, we thought so that the possibility of the students not necessarily being able to come to our specific locations or sites, but us being able to go to where they're at collectively would definitely create more of an impact. And then also we have here in the next photo, just our different departments, DSCP going out into the community and just really providing that social interaction that sometimes is missing within the community. Next slide. Okay. Again, just a graph that indicates our growth. As you can see, we're on a steady climb where we started with less than 4,000 patients, or right around 4,000 patients in 2008. And we moved right up to about almost 12,000. And then with the COVID-19 pandemic, we were also impacted. We did implement some telehealth services, as many other providers did, to try to accommodate and be able to assimilate some of the limited factors with regards to social distancing. We had to make quite a bit of adjustments, even with our dental health services. Of course, with providing dental health services, there's more of a risk with regards to the type of procedures and processes that are taking place from a respiratory standpoint. But we were able to implement some air filters and some different dynamics that allowed us to at least provide emergency care services for some time. And now with the reductions and the restrictions and different safety precautions in place, we do think that for 2022, along with the introduction of new dental sites that allows us to have additional operatories or dental chairs, we can definitely really get to the forefront of providing dental services to these patients. Next slide. So the visits in correlation to the patients, as you can see, when comparing, they would say that the less that individuals may see the doctor, even if they have their annual well visit or just a follow-up, that's a good correlation of the quality of care that we are providing. So with the addition of dental services, the addition of our case management services, I think these two graphs, when in correspondence with one another, really do show that the healthcare that we are providing is of quality, and it is making an impact to the patient population here in the Virgin Islands. Next. Okay, this is just a real basic illustration of their patient population as far as it's spread out amongst the three identified main areas, that being Kings Hill with 32%, Christiansted with 36%, and Frederiksted with 32% as well. Okay. All right, just some numbers with regards to the life expectancy. We see in the United States, we have 76.1 years, and in the US Virgin Islands, 69.5 years. And then for women, it's 81.1 years and 78.8 years. It's interesting to look at this information, and it touches home because I remember growing up, you know, with individuals from the mainland or the continental United States was come to the Virgin Islands and would say, oh, how old are you? You guys look so young for your age, and you know, this and that. And here it is now, we're seeing that the life expectancy, we're actually below the United States standards. So we have the fresh air, we're close to the ocean. So that may be an indication that we really need to put some emphasis on quality healthcare. As we know, those of us who are here, oftentimes individuals have to travel to the mainland for quality healthcare. My CEO, Ms. Webster, herself was sharing a story of having to travel off island to get access to care for a particular family member, which of course, you know, includes transit, boatways, airfares, hotel accommodations, etc. And then too, with the impact of Hurricane Maria, etc., patients having to be airlifted to Puerto Rico and to Florida, you know, became quite costly on all levels. Okay, so basically what we're trying to do with regards to Frederiksted Healthcare is really just zero in on those primary care services, which can allow us to basically minimize chronic diseases that can be managed or even be prevented if individuals are coming in for routine preventative care screenings, etc. Next slide. Okay, some of the top causes of mortality in the Virgin Islands. I won't go through all of these, but you can see on the slide with regards to the United States and the US Virgin Islands, what those are indicated and what those look like. Okay, next slide. Okay, immunization rates. We see the United States, Florida, Puerto Rico, and the US Virgin Islands. And I guess sometimes when individuals think about immunizations, sometimes the focus is just on children per se, but we know that there are some immunizations that do happen at older stage, whether it's pneumococcal vaccinations and so forth, or even flu vaccinations that are given at different stages. Okay. So next slide. Okay. So here it is. Just recently, we had a Pride event here, as you can see right in front of the health center, where there were many participating entities and community partners throughout the island of St. Croix, and just came to celebrate the spirit of inclusion and not exclusion, to really be supportive of all members of our community across and abroad. Okay. So while that, I also want to just kind of stress a little bit on the care management component, because I think it really ties in to a lot of what the other presenters have shared and said. And that's just really understanding that providing quality care has really expanded outside the four walls, whether it's due to our referral tracking or even just our PCMH designation, where we really use our care managers at Fresno Healthcare to really just identify shortages of manpower. There may be some organizations who have a designated role, but don't necessarily have the manpower or the resources to really provide the assistance that's needed. So just outside of just our healthcare providers, our doctors, our physician assistants providing quality care, is really having the clinical support staff, but just the staff in general, try to fill in the gaps in providing those areas. Now, with that being said, one of the things that St. Croix definitely suffers from is that we're actually considered a high provider shortage area, okay? That's something that comes from HRSA. Basically, the highest score a community can receive is a 26, which indicates the greatest need. And FHC currently has a score of 26. Okay, we are in dire need of healthcare staff on St. Croix. Before COVID-19, we were short-staffed. And moving right along, with a shortage of medical providers and so forth, it has been impactful in regards to providing services. Next slide. Okay, just another celebratory time here with the Mukujumbis with regards to cultural sensitivity. Next slide. Okay, this is our staff here with a National Health Center weekday. Next slide. All right, thank you for allowing me the time to share some of this information. Okay.
Great, thank you so much. Yeah, what a great presentation. And, we saw in the slides today from all the presenters, a lot of data that's really interesting, a lot of information on programs. I know that you guys are also, especially the folks in the territory, seeing behind these numbers, seeing their needs, their stories every day. And I know how powerful that is. I know those of us that either live or have family in the territory are familiar with a lot of those stories, people being displaced for lack of access to care in the territory, having to travel for care, people struggling with housing. And just hearing about the great work that you guys are doing is really inspiring, and I really appreciate, again, the time that you spent with us today and all the great efforts that you're undertaking. We have a few minutes that we have now for a question and answer. So if the panelists can turn video on, we will go ahead and facilitate some of the questions and answers that have come into the chats and the Q&A throughout. So I think the first question that came through was regarding the social vulnerability index, and I think there might have been a couple, so I'll try to group them. So Hillary, the question was if there was any indication as to when the 2020 data might become available.
It is a good question. I think we're hoping for the end of the calendar year. It's actually UVI who gets it first, so Greg may or may not. That's as far as I know from Greg.
Yeah,
Greg.
I do not know. I think we will know when the results are out.
And then I think the next question was probably will probably be best answered by Marvin, but please, anyone, feel free to jump in. The question was around health and housing supports for persons with disabilities. There was, I guess, discussion of the elderly, but the attendee would love to hear more about how housing and healthcare is addressing issues for persons with disabilities.
Yeah, again, the strategy or model that we're implementing here at the Housing Authority, it is designed to be a benefit and service for all populations. So whether young people to working age, all the way to seniors and those with disabilities. Again, the process that we have designed begins with doing actual needs assessments in our communities and ensuring that we're understanding the needs of all populations, to include those who are disabled. Again, what's really important is that it is extremely important, actually, that we are designing housing options that meet the needs of all of our residents. For those who are disabled, that's more important, to ensure that they're properly housed. That is going to ensure that they're able to be in a situation that's going to promote healthy living for them. They need to be in communities that are resource rich, or that where they can easily access the services and resources that they need in order to live healthy lives. We need to ensure that they are in situations to where they are in housing, types of housing that makes it easy for them to be mobile and to move around. Obviously, we want people who are disabled, or maybe using wheelchair or other assisted devices, living on third floors and second floors of building. We want to make sure that they're in ADA accessible units as well. So the model that we are implementing in combination with our redevelopment plan, both of them work together to ensure that we are properly housing our disabled residents.
Thanks so much. And I see there's a follow-up question, just I guess to Romy and or Joni, on NeighborWorks in particular, and whether through the network or just knowledge of national best practices, you guys have any examples of how folks with disabilities are served through housing?
I don't know, Romy, do you?
I can't speak. I know that many of our network organizations are working with populations who have a disability, and as part of some of the tax financing structures, there are specific housing units that support residents who have disabilities and different continuum of services, but I can't point to national practices that I could speak confidently to right now.
And of course, after the session, we'll be sharing the slides and the recording, as well as websites and contact information. So folks can certainly follow up and get more information afterwards as necessary. And then I think we maybe have time for one more question. Despite the many problems of COVID, did COVID provide some positive opportunities for your organizations, such as federal funding, revenue from more visits, et cetera? I don't know if anyone would like to volunteer to jump into that one.
I could jump at that. With regards to COVID, what it did allow us to do was really to just step back and really become more innovative with regards to making sure that individuals in the community had access to care. What we found is that through telehealth services, there were some limitations depending on the type of services that were needed. There was some additional funding that may have came from just providing COVID tested or COVID vaccinations, but I think it really revamped a lot of various organizations with regards to being more equipped to provide care in a variety of different ways, especially when it came to our senior or our disabled population.
All right, thanks so much, everyone. So on this slide, you'll see some of the websites you can visit for more information, all of the organizations that have been presenting today, Enterprise, NeighborWorks, BI Housing Authority, FHC, UVI, and DPNR. Also, you can find a link to the Enterprise Keep Safe Guide, which again is a resource that we hope is very valuable in Puerto Rico as well as the US Virgin Islands. And lastly, just want to thank everyone, thank all of our attendees, thank all of our panelists for their amazing presentations and the work that they do, And thank you to our partners at NeighborWorks for the ongoing support. We will again be following up with the recording and with contact information, and we'll answer any additional questions that folks have through direct communication. Hope everyone enjoys the rest of the day, and we'll hopefully be in touch again soon. Take care.